Good morning, all you cool cats and kittens. This lecture is going to be the first half of this slide. I've got chapter 17 and 18. 17's elbow and forearm, 18's wrist, hand, and fingers. I've condensed both down. I've just kept them on one document, but so there'll be two lectures for this one. So we'll get started with chapter 17. Main ideas. With elbow bony anatomy, you've got our lateral and medial epicondyles. Medial epicondyle is always going to be a little bit larger. Medial epicondyle a little bit more rounded, more smooth. Again, those are our sites for our attachment for extensor tendon and flexor tendon. Between those, we have the capitulum and the trochlea. Radius is going to pivot or rotate on the capitulum, and then ulna is going to move on the trochlea. All right. Change this up a little bit for you, help you see that. Radius, ulna, remember radius always follows the thumb. Ulna will always be in line with the humerus. We have the coronoid process and the olecranon process, so it forms this U shape, okay, which rotates around that trochlea. And there's that radial head, sits on the radial neck with the radial tuberosity. So capitulum would be up here, trochlea would be here, lateral epicondyle, medial epicondyle. Then down at the wrist, we have the styloid processes, two very commonly fractured areas of the wrist. Now, with the elbow, we have three joints in a single capsule. The first, humero-ulnar. That is our hinge joint. Okay, so that's where we get our flexion, our extension. Our next is humero-radial pivot. So that's going to allow us to pronate, supinate. And our last is going to be that proximal radio-ulnar. And again, we see some pivoting there. So there's our three main joints within one capsule. So the elbow we always think of as just this very simple hinge, but there's actually three distinct joints within one capsule. So a little bit more complex. So again, imagine one capsule surrounding those three bones. Within that capsule, though, we have three ligaments. This first one that we see, this is the UCL. Three distinct bands, anterior, transverse, and posterior. When we talk about Tommy John injuries, UCL tears, this is the ligament that we're going to focus on. Again, UCL helps prevent against valgus forces. The RCL still has distinct fibers, but it also fuses. It creates this annular ligament, which keeps the radius head in place. So RCL prevents against varus forces in the body. We don't see as many varus forces. Valgus forces are much more common. So we don't see a ton of injuries to the RCL. It can happen. But again, that radial collateral ligament just helps prevent against varus forces. UCL valgus, RCL is going to be varus. In between, running the entire lengths, so again, radius, ulna, styloid processes here, we have an interosseous membrane. Okay, it's stretchy. It allows that radius to pivot and to rotate and to spin, so it has some stretch to it, but it just helps keep those two bones together. Very similar to the lower leg, the interosseous membrane between the tib and the fib. Muscles. All right, remember everything on the posterior aspect of the forearm is going to be an extensor. Everything on the anterior is going to be a flexor. Big ones, we have extensor digitorum running into four different slips. So as you type and as you look at the back of your hand, that's the tendons from extensor digitorum. Brachioradialis is up here. That kind of serves as our equator. Everything behind brachioradialis is going to be an extensor. Everything in front of brachioradialis is going to be a flexor. There you can see flexor carpi ulnaris, though. It kind of runs right along the ulna. And then down here we have our snuff box tendons, which we'll get to more in chapter 18. Okay, so the main extensor is going to be extensor digitorum. Off of that, you have an extensor digiti minimi, runs to your fifth digit. And then there's also an extensor indicus, which runs to your pointer finger or your second. So they kind of sandwich that extensor digitorum. There we can see the flexor group. Main flexors, we got flexor carpi ulnaris, palmaris longus, and then flexor carpi radialis. So those are kind of our big three. Now the nerves. We've got three segments. Again, these are all branching from the brachial plexus. We have radial, ulnar, and then median. Okay, median's going to run through right in the middle. Radian stays lateral, and then ulna tucks behind that medial epicondyle. So when we talk about funny bone, right in here. Okay, and then there's a nice groove to allow that ulnar nerve to sit and be protected. Nerve sensation of the hand, a little bit unique. The median nerve is thumb, second, and third, and then a portion of your ring finger, but it's essentially the entire palmar aspect of your hand. Ulnar gets the other half of ring, and then your fifth, and then a portion of your palm, more on the back side. And then radial is really just kind of split between ulnar and radial on the back side of your hand. So again, nerve distribution is kind of unique. It's not exactly what you think, but just a good concept to keep in mind. Now that median nerve is going to run right through what we call the cubital fossa. Okay, so this is the soft spot, the soft area formed by brachioradialis, pronator teres, and then at the top we just draw a line right under your biceps. So this would be looking at the anterior view. So that's the cubital fossa. Okay, that's where we go. We can feel that brachial artery. Deeper, there's that ulnar artery, and then radial artery as well. So a very, very important issue for soft tissue passage. Now, carrying angle. We look at carrying angle, basically drawing a line from the humerus down through the forearm into the hand. Women are going to be a little bit higher. They're going to be anywhere from 10 to 15. Men are going to be from 5 to 10. So cubital valgus is excessive carrying angle, and then cubital varus is a decreased carrying angle. So cubital valgus is excessive, cubital varus is a decreased. We look at gunstock deformity, which is reverse. And I've got a picture of that. So there you can see more of a normal carrying angle, and this person this is actually a result of an injury, but they have what will be known as a gunstock deformity where they reversed that carrying angle. Again, I like this picture. It shows we've got cubital varus, normal angle, and then if we imagine cubital varus, the hand would sit in here. Okay, so cubital varus, I always think of that. It looks like your hands are going to sneak into your pockets. Cubital recurvatum. Cubital, again, we're talking about the elbow. Cubital recurvatum is going to be hyperextension. Most of us do have some degree of hyperextension. Females will be a little bit more than males. All right, elbow injuries. Elbow dislocation, mechanism of injury, traumatic force. All right, we're going to see this with falls, some sort of weight. Almost all elbow dislocations are going to be posterior, and they involve vast majority involve some sort of fracture. Our rule with an elbow dislocation, okay, never reduce. Never, ever reduce. We want to splint, check vitals, check posterior sensation, and refer. Signs and symptoms, the elbow, the olecranon process will be prominent. It will be pushed back. They'll be unable to move the elbow. We can see a few pictures here. Very, very traumatic. There's the prominent olecranon. A great deal of elbow dislocations occur with Olympic lifts. Again, because we have often a high velocity force with a lot of weight, and that elbow just shears. Again, do not reduce. Other professions are going to have a little bit different view on this, but as far as an athletic training and sports medicine, it's kind of a legal gray area, so I would not recommend reducing. UCL injury is much more common. Here we're kind of getting in that Tommy John. We tying in with our video from the previous week with the baseball players. We call this valgus overload, so excessive valgus force stretches out that UCL. With some UCL, you might have ulnar nerve issues, so kind of some numbness and tingling in the hand. But over time, this leads to a rotary instability. which will cause that gapping and gets us to that Tommy John. Most of the time we try and treat elbow pain with shoulder rehab or mechanics. Oftentimes if we catch a UCL injury or that gapping, that rotary instability in the early stages, we try and just address mechanics, strengthen the elbow, strengthen the wrist, strengthen the shoulder, and make sure we have a proper biomechanical chain. RCL injuries, very rare, very rare. We see this sometimes with like hockey or football where there's a collision, your arm gets caught in a position and moves. It's going to cause some of that pain, laxity, but just on the lateral aspect of the elbow, nothing on the medial. All right, epicondylitis, tennis versus golfer's elbow. Basically, remember, we have one tendon for multiple muscles on either lateral or medial epicondyle. If it's on the lateral epicondyle, we call it tennis elbow. If it's on the medial epicondyle, we call it golfer's elbow. All right, in tennis, you have a lot of hyperextension. With golfer, there's a lot of flexion. So that's how they get those names. Basically, this is a self-limiting condition, just caused pain in the elbow. We'll see kind of an achiness. There shouldn't be any laxity or looseness, but again, rest, ice, some strengthening helps to treat these issues. Little leaguer's elbow. Okay, we see an apophysitis where the muscle starts to pull away from the bone. Our main idea with little leaguer's elbow, is we just have muscle pulling away from the bone. It's caused by kids throwing too much. Okay, so again, kids really don't develop epicondylitis. They're more of an apophysitis situation. Okay, the signs symptoms mimic the epicondylitis, but again, the pain doesn't go away. Okay, so the pain is continuous. Pain does not go away. Nerve issues. Again, because we have 3 nerves that run through the elbow and feed the hand, we're going to see a lot of kind of unique and kind of interesting things. But general signs and symptoms: numbness and tingling, impaired sensation, difficulty grasping, difficulty picking things up. But anytime we have a nerve pathology in the hand, make sure we don't have any C-spine injury or C-spine issues. All right. First one, ulnar nerve, is cubital tunnel syndrome. We kind of call this the funny bone. But what happens is that ulnar nerve, it can become trapped. It can also undergo a tremendous amount of pressure. But then we have this cubital tunnel as the ulnar nerve runs through the elbow and then dives through the forearm. Pressure's increased and it just pinches that nerve. So somebody with ulnar nerve pathology is going to have numbness and tingling in their 4th and 5th. With that ulnar nerve pathology, positive Tinel, so as you tap under that medial epicondyle, it's going to cause numbness and tingling. Sometimes your patient might have a snapping. But over time, you'll see 2 things develop. Number 1 can be what is known as Wartenberg's sign, where your 5th digit or your pinky is just kind of lazy and it hangs off to the side. But if we let this develop for years, you'll actually develop what is claw hand. So your knuckles will be an extension and your IP, so your finger joints, flex. So we call this claw hand. Forgive the picture. With carpal tunnel syndrome, that's a median nerve issue. Again, looking at people anywhere from 45 and up, repetitive movements, office workers, construction workers, laborers, factory workers, they're going to be most at risk. But with carpal tunnel, if you look at your hands in the palmar view, you can see the 2 raised areas in your palm. That shallow part in the middle, that's your carpal tunnel. We get pressure, we get scar tissue, puts increased pressure on that median nerve. Forearm compartment syndrome can happen. Again, we look for the 5 Ps. Volkmann's ischemic compartment, or excuse me, Volkmann's ischemic contracture. This is a result of compartment syndrome where basically the tissues die in 6 to 12 hours, and it leads to this permanent flexion contracture, which is pretty rare. The last thing, when we have humerus and olecranon fractures, I just love these pictures. Look at the hardware that's involved with these 2. So again, they're just trying to piece things back together. I'm going to stop there. I'm running to my 15-minute time limit. I'll catch you guys in the next lecture.